Hi, everybody. This is Jan Bellows, veterinary dentist from Weston, Florida. This is going to be a whirlwind tour of veterinary dentistry. And the most important concepts that you're going to get out of this is when you open up the dog or cat's mouth and you see something, you're going to really understand what is the next step. Is it something that you can treat? Is it something that needs to be followed? Is it something that needs to be referred? So we're going to review congenital problems, orthodontic problems, inflammatory problems. We're going to talk about tumors, and we're also going to talk about periodontal disease a lot. So let's start off right at the beginning with, kind of understanding that it's a challenge for what we're all doing. There is so much medical issues and surgical issues, potential surgical issues going over in a dog's and cat's mouth. Most common oral problems that we're going to talk about is missing and supernumerary teeth in dogs and cats. That's congenital problems. Periodontal diseases, and it's more than just periodontal disease. This disease is gingivitis, periodontal disease proper, gingival enlargement, and oral nasal fistulae. Then tooth resorption, oropharyngeal inflammation, gingival stomatitis in the cat, tooth trauma, and orthodontics. One of the really nice things about dentistry is that there's only so much that you really can do to treat the animal. And generally, when you treat them, they get better real quickly because you're taking care of the problem, and the body has a wonderful ability to heal. So one of the more common things that we do is if there's a functional problem, which means that it's abnormal, however, the animal's not really bothered by it and they can still eat without pain or discomfort. And the treatment of that is follow-up, because some problems are progressive. And if they progress to the point that it's painful, you want to take care of them. Another problem or solution is removing the plaque and calculus. And understand that plaque forms calculus within 3 days. And calculus is rough. Calculus is also called tartar. And because it's rough, more plaque forms on it. And it's the plaque that leads to periodontal diseases and gets all the problems, majority of the halitosis and the pocketing and the disease spread to distant organs. It all comes from plaque. So removing the plaque and calculus at least once or twice a year is highly recommended. The third thing that we can do, and we're going to talk about it today, is the installation of local antibiotics. They're called LAA, local antibiotic administration, and that's either clindamycin or Clinderol or doxyrope. And this is indicated in stage 2 or 3 cleaned periodontal pockets with less than 25% support loss. When it gets greater than 25% support loss, usually the pocket is deeper and it's hard to clean. So just by placing antibiotics in there, it's not going to help very much. The fourth common treatment is vital pulp therapy when you have an acutely fractured tooth, or if you want to do a crown reduction to help with orthodontic problems. The fifth is restoration. That's when you have a fractured tooth, an uncomplicated crown fracture in a young animal, and you want to make it further away, the fracture site further away from the root itself. The sixth is root canal therapy. And unless you have special training, we recommend that you refer that. The seventh is crown reduction and restoration in cases of type 2 tooth resorption. We'll talk about that. That's crown reduction and gingival closure, crown reduction and restoration in cases where we want to cut a tooth in half so it doesn't impinge on the palate. The most common, unfortunately, or surgical procedure that we do is extractions. And sometimes after several cases in a day, then we extract a good deal of teeth. You feel like that's all you're doing. But unfortunately, because there isn't very much prevention going around, or not enough prevention going around, we have to extract teeth. Hopefully that can change with everybody's help. And the last thing is orthodontic movement. So we generally, with orthodontic problems, we either remove the tooth or move the tooth to a functional position. Let's start with missing teeth, congenital problems. Generally, if the animal is less than 9 months old and the tooth is in a proper orientation, which means that it wants to come up normally, but it's being held in by thick gingiva, then we do a procedure called an operculectomy, which actually takes away the thickened gingival tissue on top of the tooth and lets it emerge. If it's greater than 9 months old, then we want to take out the tooth because the emerging force isn't there anymore. It just doesn't push up. And if it's in an abnormal orientation or embedded, we would want to extract. So take a look at this tooth at the bottom, and you can just see that there's the adult teeth, which are your incisors down here, and they look fine. And your premolars here, they look fine. But what are we missing? We're missing canine teeth. So the next step is to take a radiograph. And when you take a radiograph, you'll see that the canine teeth are there, but they are unfortunately embedded. So in this scenario, I went in ventrally and removed these canine teeth. And that way we were able to save the dog a lot of aggravation and cysts in the future. So that was embedded canine teeth. How about in this scenario? There's a clinically missing mandibular first premolar. So you look at the mouth and you see, something's missing here. And then you take a radiograph and it's sideways. And not only it's sideways, a cyst is forming. That is not only affecting the first premolar, but the second premolar too. So you go in here and remove both the first and second premolar. You consider placing some bone graft material because the canine doesn't have very much support down here. But generally, if you get a good clot, the bone will rebuild. Here's another case where you have the tooth that's missing, but it's coming up in a normal orientation. And this is very common, especially in spays. Spays of micropets here, Yorkshire Terriers, miniature Schnauzers, Chihuahuas, Pushton dog faces, your pugs and your French bulldogs. Half of them will have a missing premolar, and half of those need surgery. So the surgery that we perform is something called an operculectomy, where we come in and remove the tissue on top. I did this with a laser, but you don't need a laser. You can do it with a cold blade. And just remove the thickened gingival tissue on top. And as long as the dog is less than 9 months old, or cat, then the tooth will be expected to emerge to normal location. So that's missing teeth. The other side of that is too many teeth. And too many teeth are characterized by persistent primary teeth, which is in this scenario where the primary tooth, the baby tooth, just stayed around, and it's actually pushing the adult tooth too far outward and causing a swelling. So that's persistent primary tooth, but this is supernumerary teeth, where we just have too many teeth. So normally there should be 6 incisors. You see 3 here, and 1 more. So that's 7. And because the animal then lacks the self-cleaning mechanism in this area, we go ahead and remove the supernumerary tooth. Take a look at this English bulldog. On this side, you have the canine, the first premolar, second premolar, third premolar, fourth premolar. But on the other side, you have the canine, first premolar, second premolar, third premolar, third premolar, third premolar, fourth premolar. So you have 3 extra teeth there, and you see the inflammation and the way the orientation of the teeth. So those 2 in the middle really need to be extracted. Cats get it too. And you see just how swollen this cat's gingiva is, because essentially there are 2 feet in the same shoe. So it swells out and it's painful. And you can see in this dog, it created a place for debris to form and for periodontal inflammation and the whole periodontal ligament is being stretched. So this little dachshund is going to be predisposed to periodontal disease later. And not only there's two teeth in the same socket at the same time, which causes a swelling, but the primary tooth pushes the secondary tooth forward. And you can see that crowding out, so the secondary canine tooth has no place to go, especially because the primary canine tooth, the mandibular one, is pushing it too far inward, and that's where you get the palatal impingement or penetration. Now, it's very important before you take out these teeth to take radiographs. And you see on the right side here, this is what we want, very thickened dentin here and thickened dentin here. So it's going to be fairly easy to remove this tooth without fracturing it. But you look at this side, and the dentin in the crown is pretty thick, but you see in the root, it's really thin. And it's going to be hard to remove that tooth without getting into trouble. So that's why we do it surgically. So here's the first one. We go ahead and take a number 11 blade, not a number 15 blade, but a 11 blade, which has a pointy end, goes right in the gingival sulcus. And then we use a sharpened wing-tipped elevator to go all the way around the root at the right at the right angulation, go all the way around that deciduous tooth, and then remove it. And I remove it with a rongeur compared to an extraction forceps. So gently wiggle it one side and the other side, but I don't keep on going back and forth and back and forth and back and forth. I torque it to one side, keep it for 10 seconds, torque it to the other side, sometimes take the wing-tipped elevator back again and go ahead until it's really mobile before I remove it, because I don't want to fracture the root. If you do fracture the root, and if you determine you're going to cause more damage going back after it than just leaving it alone, my recommendation is just leave it alone. Most of them tend to do really well. Now, in the open case, when you have that tooth resorption, we take the blade right along the wing-tipped elevator, made an area where to take the pressure off when we're trying to luxate that tooth out of the socket. Then we're able to pull it out almost by hand, by finger, and then put a couple sutures there. So the open extraction, it can be done for both cases, but certainly for the ones that when you radiograph, you see that there's a very thin dentinal wall. I'm going to spend some time on periodontal disease, because periodontal disease is the most common of all diseases in animals. And normally, the gingiva should come right up to what they call the cemento-enamel junction. Here's enamel, here's dentin, and right over here where the dentin is attached to the root, that's called the cemento-enamel junction, the cementum-enamel junction. And that's also where the end of the sulcus meets. So this area here is the sulcus. Here's the cortical bone. On the other side that has periodontal disease, and you have gingival recession, you have a pocket. And you see how deep this pocket is. And unfortunately, a pocket is not a good thing. And the goal for periodontal disease treatment is to eliminate the periodontal pockets. And most commonly, we eliminate it by taking out the tooth. But there are other ways. We can do a gingivectomy. We can instill the local antibiotic treatment. We can do fancy periodontal surgery. But the goal is not to actually get to this point where you have a pocket, because having a pocket is, food that the animal eats just sits there. And you can imagine if you took breakfast or lunch or dinner and put it into your pocket and never cleaned your pocket out, eventually your jeans would rot, and then your leg would start rotting, because the food doesn't belong there. So we'll start with the normal. And the normal gingiva should have the marginal gingiva here with a lot of capillaries just laying very benignly against the tooth in what they call a knife edge. They call that a coral pink knifed edge free gingiva right there, or marginal gingiva. All right. This is unfortunately what we usually see because animals don't brush their own teeth. They start getting in trouble. And the first stage of periodontal disease, there are 4 stages. The first stage is called gingivitis, which is inflammation of the gingiva. And there is no support loss. That's the big deal between gingivitis and periodontal disease. Once you get periodontal disease, you have support loss, which you don't want because it's progressive. So with gingivitis, the therapy is to remove the plaque, and we do that with ultrasonic scaling and hand scaling, remove the calculus, and then daily plaque prevention. And that is achieved through the vohc.org website products. So it's vohc.org, Veterinary Oral Health Council, vohc.org. And you'll see many products for dogs and cats, and those products have been accepted to at least decrease the progression of plaque and or calculus, whichever one they applied for, and some of them do both, by 20% in 2 double-blinded studies, an average of 20%. None of the studies has to be less than 15%, but the average of 20%. The question about anesthesia-free dentistry, or what they call non-anesthetic dentistry, comes up often. And even though a lot of the corporate non-anesthetic dental companies do a really nice job of removing plaque and tartar from the crown, that's not where the disease is. The disease is below the gingiva. It's way down here, and you can't get to it with the animal not being anesthetized without causing a lot of pain and possible injury to the animal. You also cannot take full dental x-rays, full mouth x-rays, without general anesthesia. And that's why both the AVMA and AHA mandates any dental procedures has to be done under general anesthesia with the patient intubated. And that's specified in number 1, number 2, and number 3 of the AHA dental guidelines, and also specifically specified by the AVMA. So stage 1 is gingivitis. Stage 2 is we start to get bone support loss. And you can see here, we take a periodontal probe, and it's usually, this is 5 millimeters, so it's 4 millimeters, and the normal amount of millimeters in let's say a beagle dog is probably 1 or 2 millimeters. It shouldn't go more, but in a Great Dane, it'll be 4 or 5 is normal. And then we take a radiograph and we look for the bone level. And generally, the number 2 disease is less than 25% from the CEJ, from the cemento-enamel junction, down to the bottom of the root. So less than 25% is stage 2 disease. And with stage 2 disease, the treatment depends on whether there's recession or not. If there is gingival recession and the tooth is clean, then there's no more treatment. But if there's a pocket, you want to eliminate the pocket. And to help decrease the pocket size, and also to treat teeth that have bleeding on probing, we use local antibiotics, LAA, locally applied antimicrobials or antibiotics. The one I like the best is Clinderol because it costs a lot less than the alternative, and it's easier to use. It stays in there where the alternative sometimes comes out. Here's some samples of, here's a dog that is bleeding on probing. And I recommend placing the Clinderol in areas where there's bleeding on probing, because if you probe the mouth and this tooth doesn't bleed, this one does, this one does, the one that didn't bleed, it's because that gingiva is healthy. The sulcus is healthy, but in the ones that bleed, it's inflamed. So you want to try to turn that around right away. So after we diagnose where it is, then we blow some air in there to make sure that it's all clean, instill the Clinderol, and there'll be a little bleb at the end. Same goes for the first molar here. We wound up probing it. It came out with a 4-millimeter pocket, cleaned it, blew air in that area. You can see how the lip just flares out a little from the air coming in. And then we installed the Clinderol right into that periodontal pocket. You can see how a little bit came out right in the distal root. All right, stage 3 disease has between 25 and 50% support loss. This is probably the hardest one to figure out what to do, because in stage 3 disease, it's going to be progressive in time to stage 4. And if a client can clean the teeth daily, and we recommend dental wipes, and with cats, we recommend a Q-tip soaked in tuna juice. If the client can apply that once a day, you will decrease the progression of periodontal disease. If they can't, it's best to take out the tooth. So you can see here where there is normally between the CEJ, cemento-enamel junction, and the bottom of the tooth, there's 100%, and here is less than 50% of support loss, but getting darn close to it. And the other side, there's what they call a furcation exposure here, but still from the CEJ to the bottom, it's less than 50% support loss. So that's where you get the stage 3 disease. Here's an example where you see on the 4th premolar here, it's just about at that 50% range. And the first molar also has periodontal disease. However, it's a big tooth to take out, and the dog would like to have it if possible. So in the end, I decided to take out the 4th premolar, and the owner promised to do great home care. And our home care, we recommend a dental wipe every day. And as far as what's in the wipe isn't as important as the friction. And you just have to advise your clients to wipe the outside surface, the buccal surface, or the facial surface of the teeth. The inside, the tongue takes care of. Stage 4 disease, once we get here, game's over. Once it's greater than 50% support loss, most teeth will be mobile. You're just not going to save these teeth. There's not going to be anything that you could do humanely that's going to save these teeth for the dog. Stage 4 periodontal disease also comes with pockets. But stage 4 periodontal disease, we take out that tooth. You'll hear the term furcation, a furcation involvement, furcation exposure. The furcation is a normal anatomical structure in between a double or a triple rooted tooth, right at the trunk. You place your probe into the furcation, and if it doesn't go in greater than half, but it goes in, then that's called a furcation 1, stage 1 involvement. If it goes in greater than halfway, but doesn't come out of the other side, that's stage 2. If it goes through and through, that's a problem. That's stage 3. And both stage 2 and stage 3, we usually extract because it's very, very difficult to take out those teeth and to keep them clean. Food and debris are going to get in there virtually no matter what you do, because it's a place that you really can't brush well. So that's stage 2 and 3 furcation disease. Still on periodontal diseases, some animals have gingival enlargement, where you have a hyperplastic gingiva. And it's still a problem because food and debris will come right in this area here and cause issues, require more inflammation. And this is a very common problem. And you'll see the treatment of choice is gingival, you just either with a blade or with a blade and a laser, you trim away the excessive attached gingiva. It's called the gingivectomy. And this is time of surgery, and this is 2 to 3 weeks later after the client every day has to wipe the teeth. Continuing with periodontal disease, some animals have palatal defects where you could place the periodontal probe almost down to the nose. But if it goes into the nose, then game over. Then you have to take out the tooth. But if it doesn't go to the nose, at least you have a fighting chance of placing bone graft material into the infrabony pocket and then sewing it back. So here is us flapping it on both sides, opening up the flap. You see the gingival tissue here. Then that is cleaned out, makes a big hole, and the hole we fill with bone graft material. And then sew it back. Unfortunately, sometimes the periodontal disease progresses to oronasal fistulas, where you look in the mouth and you see the nose, and that's something you don't want to do. Most commonly, this will occur in the Dachshund breed. They have long, skinny noses, and there is treatment for it, but you need to remove the teeth, then suture the defect closed after removing the epithelial collar. You suture the defect closed without tension. The key here is without tension. And they usually heal fine. All right, so let's review the concepts. Stage 1 is gingivitis, remove the plaque and home care. Stage 2 is early periodontal disease, less than 25% support loss. And if there is a pocket, you do a gingivectomy or consider a Clinderol. If there isn't any pocket, then just send the animal home on home care. Stage 3 disease is established periodontal disease. That's between 25 and 50% of support loss. And in that situation, you would do what they call an apical reposition flap, which you would most probably refer, or more commonly extract the tooth. Non-pocketing disease, home care or extract, and stage 4, extract. All right, so that's congenital and mucositis, congenital and periodontal disease. The next is contact mucositis, also at one time called CUPS, which is chronic ulcerative periodontal stomatitis. But they found out some of these cases aren't chronic and some are not ulcerative. So now it's called contact mucositis, where this rough area rubs against the mucosa and it causes inflammation in dogs that are predisposed, that have hyperplastic or hyperimmune response to plaque. So the treatment is remove the plaque in the area. You can see the same thing on this side. See what the inflammation here is here? So most probably this tooth is going to come out, this tooth, and most probably some others too. So it's contact mucositis or stomatitis, and some cats come in really bad shape. So here's a cat that presented with the oropharyngeal inflammation. We also call that caudal stomatitis. And the reason why he was presented to us was because the referring veterinarian had problems intubating. It was that swollen. Other times, the inflammation is focal. And when you radiograph the teeth, oftentimes you'll see tooth resorptions in these areas that are percolating out to the attached gingiva. If the inflammation is localized and not generalized, or local or not so severe, we call that alveolar mucositis. So it's the alveolar mucosa that gets inflamed. And we see that very often. And sometimes in little kittens, the alveolar mucosa is all inflamed. That's something to be attached to. And what happens is if you trim away the excessive tissue, and if you put the cat on a good home care control program, most of them will grow out of this. All right, caudal stomatitis, that's a big problem. This is, the cat is immune or hyperimmune to its own plaque, and especially when you see these lesions in the back, that carries a worse prognosis than if they're not there. At one time, this is called faucitis, but the fauces are in this area where the inflammation is in the caudal oral cavity. So we call this stomatitis is inflammation of the caudal oral cavity. And this comes in lots of varieties, but there's only one treatment of choice, and that's to extract the teeth. So the choices are, we extract all the teeth, or just the teeth caudal to the canines, if the canines and incisors aren't inflamed, or we extract only the teeth in the area of inflammation. What usually doesn't work is medicine. And at one time, we were treating this with repositol steroids, and that is not a good idea, because what will happen is that the steroids will work for a while, and then they decide not to work. So then you use more steroids, and they'll work for a while, and the client will think you're great, and then decide not to work in a lesser period of time. Then they'll do it again, where they'll go ahead and work for a while after the third injection. And each time the remission is shorter and shorter. And depending on how many times you give it, you can create a diabetic cat. And you certainly don't want to do that. The antibiotics and the anti-inflammatories work somewhat, but it's not like the animal has the deficiency, a non-steroidal deficiency or antimicrobial deficiency. They have a hyperimmune response to plaque. But there's been so many medications that have been tried to help, and very few, if any, still continue to help. What has been known to help is interferon. And interferon, the good news about it is it really works when given in these different protocols. The bad news is that it's really difficult to get. It's a real hassle to get it. So it's something that we usually don't recommend doing because of access, not because it doesn't work. The quintessential case where it's all started to see what to do with gingival stomatitis, Dr. Philippe Hennet wrote an article that took quite a few cats and removed the teeth, either full mouth extraction or just those ones behind the canines. And he found a cure rate of 60%. He found 20% needed additional care. And in our practice, what additional care is a laser. We use a CO2 laser, cutting edge CO2 laser, once a month for 3 months. And then the third group just didn't get better. Fortunately, we haven't been faced with the third group. I don't remember one cat that didn't at least improve. Some of them don't get cured. Some of them still have a little bit of inflammation, but they usually do really, really well. So that's what it looks like when they come in. The ones that don't have the caudal oral cavity inflammation have a much better prognosis. If you come in and you see a cat that has inflammation around all the teeth and you convince yourself those teeth have to come out, if there's no inflammation caudally, the prognosis is great for the inflammation to disappear. In this case, we extracted all the teeth behind the canine, and you can see beforehand and after. So the inflammation goes away. Here's another case. Beforehand, now this is selective because there was minimal inflammation in the incisors, minimal probably around the canines. More and more as you went further, we were able to convince the client to allow us to leave the canines and incisors, and you can see how well it all healed because we took out the bad teeth, the teeth that were affected. Here's a scenario where there was inflammation caudally on both sides, and this is a hyperplastic or gingival enlargement on the bottom, a periodontal disease with actually a root showing. The key here is to take radiographs. And you can see on the molar, there's this where the bone support is here. So this is stage 2.5, 3 disease. And the treatment for that, because of the inflammation, because nothing you're going to do is going to bring the gingiva up, we extracted that tooth and the tooth on top of it. The suture material I like is catgut. I usually use either 4 or 5 catgut on a P3 needle. So that's how it healed. It started this way. Actually started that way. And then it went to that surgically. And that's how it healed. Healed really nice. Now in this scenario, this cat was born with an extra 4th premolar. So I had 2 4th premolars. And because of that, he had excessive plaque and tartar in this area. You can compare it to the cat's normal side, which has no inflammation. And this is after the extractions. And about a week after that, on recheck, the dog was doing much better. The cat was doing better. So the essentials for extractions, really important, is the extra sharp wingtip elevators. Lots of companies make them. You want to put oil on a Arkansas rock, then take the periodontal probe and go from side to side and just make sure that it's really sharp when you pull it out. Extra illumination really helps also. It's important to see what you're doing. I've always used the Perioptix. My dental resident, Dr. McMorrin, likes the Surgitel product. There's a human product called Designs for Vision, which is really good. So there are a lot of options out there. Intraoral x-rays are a must. If you don't have the capability of intraoral x-rays as compared to skull films, then you should consider referring. Because if you're going to take out this tooth, you see how this root is fine, yeah, that'll come out, but this one, it's going to be impossible to take out. So if you only take out half of the tooth and you keep on jumping in and trying to get more because you don't see what's going on underneath the gum line, that certainly is a problem. So here's beforehand. And I generally mark the teeth I'm going to take out. This is how we took them out. And one of my favorite instruments is a flat molt 2, M-O-L-T 2, where it helps to remove, probably the hardest part on this whole thing is separating the attached gingiva from the bone. So we take a blade first and then blade pulled back here. And then we use the molt 2 on both sides. Use it on this side and then use it on the lingual side also. And then create multiple rooted teeth into single rooted teeth, and then take out each one. When you're making your when you're suturing closed, make a really large bite. Don't just go with small bites because the large bite will hold. The small bites oftentimes won't. And then when we suture single interrupted because we don't want it to open up. So that's this case beforehand. We left some teeth in there because of selective extractions, and you see how nicely it healed. Here's one that I did a full mouth extraction. It came in very inflamed, took them all out, and it healed. Here's a third one that also a full mouth extraction. And the reason why it's full mouth extraction, you can see the swelling, the inflammation on the canines and the incisors, and you see how pretty it healed once you took away the plaque retentive surfaces. That's the key here. Now, understand that the tongue in a cat is also a plaque retentive surfaces, those pointy barbs. So that's why some of the cases remain refractory. But even if they're refractory, once you take out all the teeth, they're a lot better off. In the refractory cases, we use our laser, and we do it once a month for 3 months. So even though we took out all the teeth in this cat, you still had inflammation. Cat wasn't grooming, wasn't feeling well. There are some lesions on the tongue also. So that's certainly no fun. Right over here, and certainly inflammations of the caudal. So this is how that area is what they call rastered, which is removing some of the plaque in the area. And look how beautiful it healed. It healed without any inflammation. And it took 2 or 3 months. That's a CO2 laser. All right, so we went through congenital periodontal disease, and we just went through inflammation. Now we're going to talk about the traumatized tooth. And we see this all too often, secondary to owners feeding their dogs bones or antlers. The big deal now is the deer antlers or deer ribs that they're selling in pet stores. And it's a shame they're doing it because the animal bites on it and they fracture their teeth, oftentimes below the gum line. So the first part of oral trauma to the tooth that we're going to cover is pulpitis. And pulpitis occurs when the tooth is traumatized but does not fracture. And what happens is that the pulp swells, and it swells against a bony crypt. And unfortunately, when it swells against that bony crypt, it has nowhere to go, so it dies. And when it dies, a lot of the blood cells come out and are seen clinically because they go down the dentinal tubules right underneath the enamel. And this comes in all sorts of different colors. You can see it yellow here, down here. This is a cat, it's red. Here it's gray in a dog. A discolored tooth is considered a non-vital tooth. And the treatment of choice would be root canal therapy or removal, even the incisor teeth. In humans that have discolored teeth, they complain of a dull pain. Animals should not have to live in dull pain. Different type of fractures. We start with the enamel infraction, which is also called craze lines. And these are little lines, little small cracks in the enamel. They don't cause any issues clinically, and they are not treated. They don't predispose the dog to anything. But then you have the enamel fracture. And an enamel fracture, you have the dentin below here. It doesn't enter the dentin, just enters the enamel. And the treatment of choice here, especially if it's an older dog, is to just smooth out if there's a sharp area and just let it be. If it's a younger animal, because younger animals have much larger pulps that will be closer to the area, you may want to restore that with bonding material. Then we move on to uncomplicated. Now, the classification in fractured teeth are basically complicated or uncomplicated. Complicated means that the pulp is exposed. Uncomplicated means that the pulp isn't exposed. And if you're not sure whether the pulp is exposed or not, you take a sharp shepherd's hook, put it right at where you think the pulp is, which like in this case would be over here. And if it goes in or if it sticks, then it's a complicated fracture and it's something that you really need to do something with. If it doesn't go in, then what has happened, especially in animals, let's say, that are tennis ball chewers, there's chronic irritation that the dentin produce what they call reparative dentin or a tertiary dentin, and it'll be shiny and sclerotic, and nothing will get in there, including bacteria. So there's really no pain for it. With uncomplicated crown fractures, sometimes they extend subgingivally, and then that's called a uncomplicated crown root fracture. And the treatment of choice here is you treat that fracture, if it's a young animal, you can put bonding material on it, or you can restore it with a stainless steel crown. If it's an older animal, oftentimes you don't have to do anything other than addressing the flap area. And by addressing the flap area, you would go ahead and do a gingivectomy here, removing the pocket. So uncomplicated crown fractures in a young patient restore with light cured bonding or mechanics. And the older patient with normal films, you can do nothing because there's a very, it's a far away area between the fracture itself and where the root canal is. So the animal can't feel it. In the younger animal, they become sensitive because the pulp is right there. They become sensitive to heat and cold and pressure. So complicated is different than uncomplicated. Complicated has the pulp exposed. So here's the pulp exposed, here's the pulp exposed, there's pulp exposed underneath here. So this is just a complicated crown fracture. This is a complicated crown root fracture. And in this case, here's a complicated crown root fracture, also called a slab fracture. So complicated crown fractures are a problem because bacteria get in there. And bacteria tend to percolate gingivally and periapically right around the apex of the tooth, because the bacteria goes in, infects the nerve, and all of a sudden you get an abscess that erodes the bone. Treatment of choice. If you have an acute fracture, an acute fracture is a fracture that is less than 48 hours. There you can continue to have a vital tooth. If you're the treatment of choice there would be a vital pulp therapy, where you put medicine on top of the pulp and restore the tooth. If you don't have that ability, refer it, and the veterinary dentist will know what to do to restore the tooth, and usually the tooth can stay alive. Conversely, you can do root canal therapy, especially with chronic ones. Chronic fractures, you can't do that vital pulp therapy. But root canal therapy, we take out the infected nerve and fill the tooth with something called gutta percha, which is bacteriostatic, kills the bacteria, stays there forever, and the tooth is restored. The last type of fracture we'll talk about with trauma is a root fracture. And root fractures sometimes show up radiographically. You didn't even know they're going to be there. And the tooth itself is mobile. So you want to take it out, and you want to take out the root also. In this scenario, most of the crown has come off on this tooth. Here's another root fracture. You can see right over here in a cat. And here's one that the roots have been fractured. There's no crown, and there's no areas of inflammation on the gingiva. So in that scenario, just leave it alone. It's not going to cause any problems. The other two, you need to take out all the teeth because the tooth is still there. There is fracture classification that you can get information online, and it's very easy to do. You go to AVDC, American Veterinary Dental College, avdc.org, and you can download this picture. It's under the nomenclature area. Just right-click it, download it. You don't need permission. Permission is granted, and just you can use it for any educational purposes. Now we'll talk about tooth resorption. And tooth resorption is classified in stages and types. The stages are more for scientific reasons and to talk to each other in scientific papers. The types are the part that should interest the clinical practitioner who has to make decisions. But we'll just gently go over the stages. The stage 1 disease starts at the cemento-enamel junction here and then progresses into the dentin and comes out of the crown. So stage 2 disease, TR2, is into the dentin but hasn't infected the pulp. Stage 3 has gone into the pulp and oftentimes is also right at the cemento-enamel junction. Sometimes it's missed. Stage 4 disease is a good deal of the tooth is gone, is eaten up by the tooth resorption. And stage 4A, the crown disease equals the root disease. Stage 4B, the crown disease is a lot more involved than the root disease. Stage 4C is that the root disease is a lot more involved than the crown disease. And then stage 5 is just a little bump with some scattering bone underneath it radiographically. So this would be stage 5 disease, the little bump. This would be stage 4 disease where a good part of the tooth is gone and certainly the pulp is exposed. The treatment of choice of most of your tooth resorptions is extraction. Unfortunately, at this stage, we still don't know what causes them. We don't know anything better to do. There are types of tooth resorption. And here's where we get into the possibility of treating with crown reduction or crown amputation and gingival closure. And that's only for type 2 disease, type 2. So type 1, you could still, here's the tooth resorption here, here's the tooth resorption here, but the roots are the same consistency as the adjacent roots. They're not being replaced by bone. So you go ahead, there's another resorption here, you go away and just take out all these. But type 2, the roots are being replaced by bone. And when that happens, and it's exposed to the oral cavity, you can trim down the crowns and suture the gingiva over it and let the body continue to replace the root with bone. Type 3 disease is in a multi-rooted tooth and it has both varieties. So here's the premolar with type 1 disease, and the back root has type 2 disease. So you could treat the front root by taking it out, and the back you can crown reduce it. So here's an example of type 2, where you have oral inflammation. Take the radiograph and you see how there's less opacity than the adjacent teeth because the root is being replaced by bone. In this scenario, we flap the area up, make an incision mesially, distally and mesially, open that area, and then remove a little piece of tooth here in alveolus. And then close the gingiva that was at surgery, and this is at about 2 to 3 weeks later. Heals very nicely unless the root continue to dissolve. All right, we'll talk about tumors. And most, unfortunately, there are a lot of malignant tumors in dogs and cats' mouths, but some of them show up benign. You can't tell just by looking at it, although we like to do exfoliative cytology at the time of surgery to get a good impression. The key here is how much you remove. If you just go into this area right over here and just superficially remove this, it'll grow back quite rapidly and you really haven't helped the patient. So generally, for benign masses, you have to remove the 1 centimeter in all directions. And this would be challenging to close because of that. We'd have to take out at least these 4 teeth, and we'd have to do a fair amount of undermining to get that all out, which I did. So that's the tumor after I removed the 4 incisors, and then this is the area that was closed afterwards. I retained the 3rd incisors on both sides. And that came back as what they call a peripheral odontogenic fibroma, POF. Here's another POF that we removed the root on and the tooth. Some of your benign masses are very aggressive, like the acanthomatous ameloblastoma. And for those, you have to do a very large incision, very large margins with at least 2 centimeter margins. So here, remove this area with a 2 centimeter margin, then did an en bloc excision, came in here, came down here, came up here. This is what it looked like when I removed it. And then you can see how nicely it closed. It stayed away. In the cat, both lymphosarcoma and feline squamous cell carcinoma give a horrible prognosis, and the cat should be euthanized. In the dog, they usually have better luck for a period of time. This is a dog that presented with the eye bulging out of the, the head, had a very large mass in the oral cavity that I was able to shell out. I did a lip commissurectomy, and you can see when it all sewed back together, that area that was popping out of the eye wasn't popping out anymore. And this came back as a lobar osteosarcoma, which did well for 4 or 5 months and then didn't. Some of our excisions, in order to get the 2 millimeter margins in an oral melanoma, you have to remove part of the jaw. And dogs do great without part of the jaw. All right, now let's talk about our last subject is malocclusion or orthodontics. You have to determine what's functional or not, and then determine, is it a skeletal or a dental problem? So here's normal. Here's your beagle dog, your what they call metastatic dog, where you have a scissor bite in the front, where your maxillary incisors just go over the mandibular incisors. On the cheek teeth, you have what they call a sawtooth effect. This is totally normal. Your shorter breed muzzle dogs, like the bulldog or the Pekingese cat, even though they're normal for the breed, it's an abnormal bite, because oftentimes these incisors will make holes, painful holes in the mandibular mucosa with the pushed-in-face animals. The overbites are never normal. The underbites are sometimes breed normal. If you want to see if something's genetic abnormality or not, you would want to go ahead and see if there's a sawtooth effect, which means that it's not genetic. But if they point to point, and there's holes in the middle, most probably that is a genetic defect, and the animal should not be bred. There are classifications. Class 1 malocclusion means that the backs are okay, the cheek teeth are okay, but there's usually 1 or 2 teeth that are out of place. So this would be called a rostral crossbite, where all the other teeth are in a scissor bite, and you have a couple that are out. So there's actually a cross in the middle if you look down from the top. This is a caudal crossbite, where you have your first molar, instead of being palatal to the upper 4th premolar, it is facial. And here's a situation where the maxillary canine is actually pushing down on the mandibular canine rather than being all the way back here. So class 1 dental malocclusions is a dental malocclusion compared to a skeletal malocclusion. There's some more examples of individual tooth crowding. And the treatment here is make it as functional as you can. So here you can see how this lower canine is making a hole into the upper palate. So treatment of choice is you trim this and put bonding on it, so it looks like that, and that way the tooth is still very functional and they can't cause problems. It won't cause an issue because it's not penetrating anymore. So that's dental malocclusions. Skeletal malocclusions it means that the teeth were fine, but the skull, one side, grew differently than the other. And this comes in all sorts of varieties. So the class 2, which is what they call an overbite, sometimes causes problems because these lower teeth actually make holes in the palate. Class 3 is just the opposite. That's the underbite. And you can see how this could cause an issue, making holes in the gingival mucosa here. And the treatment choice there is to take out those teeth or cut them in half and restore them. So the philosophy of orthodontics is to move or remove the tooth. And here the mandibular canine is penetrating the palate here. So we decided to move the tooth with both elastics and an inclined plane. And you can see how I was able to move it to a functional bite. When we move teeth, we put bands around them, and here's a scenario where the maxillary, unfortunately, where the maxillary canine is pulling back with the elastics all the way to the back. So the maxillary canine is interfering with the mandibular canine, and we put the elastics, and we were able to pull it back within a month. So there's a very functional bite created. All right, so in summary, think about what we discussed today with congenital and periodontal and tooth resorption and the traumatized tooth and the inflamed mucosa. In the end, it comes to 9 treatments. You do follow-up a lot of times if they're functional. You always remove the plaque and calculus. You should encourage it to do it every day with VOHC, Veterinary Oral Health Council products. Sometimes installation of clindamycin or doxyrobe subgingivally helps. Refer for a traumatized tooth that is vital pulp therapy if it's within 24 hours. Restore the tooth in uncomplicated fracture, especially in young animals. Root canal therapy to save teeth. And root canal has great prognosis if done early enough. And it's about 95% in peer-reviewed studies on success when they're done properly. You can crown reduce and restore, or crown reduce and gingival closure, extract teeth, or orthodontic movement. All right, my email is on here. My cell phone number is on. Feel free to reach out to me. You have an animal on the table, you have an animal coming in, you have a case that you need advice on, you want to send me some films, just send films. If you're sending a few films, you could send it to text or you could send it to my email. If you're sending a lot of films and if you send them often, I recommend you go through PetRaise and you'll get a nice report. If you just send an occasional film, just send it. There's no charge for it. I'm happy to help. Enjoy.